Welcome, everyone. We're going to get started. I'd like to begin by acknowledging that we're on land that which we gather on is the unceded territory of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. So we're very thankful for the ability to live, work, and play on those lands. My name is Belinda Boyd. I am Leader Community Engagement with Vancouver Coastal Health, and I'm very pleased to be the moderator today for this session. I'm going to introduce the whole panel, like for each of the presentations, but I will reintroduce them because I want to ensure that you know that you're in the right room. So the overall session is called Engage, Enable, Empower, Strengthening Care for Seniors. And our first presentation is Enhancing Early Diagnosis and Culturally Sensitive Support and Care of Dementia. And we have Leena, Jain, and Peter O'Connor from Fraser Health presenting. The second presentation will be Frail Elderly Preoperative Assessment Clinic from an idea to reality. And that is Marija Stefic-Cubic, and she is from Providence Healthcare. And the third and final presentation will be Hashtag Unit Goals, Building a Dementia-Friendly Culture in Hospital with Marta Filipski, I said I knew your name, Marta, and Jennifer Tabamo and Koren, Jaschke, and they are all from Vancouver Coastal Health. So we're going to start and welcome Dr. Leena Jain and Dr. Peter O'Connor.
Good.
I'll move out of your way.
Okay. Thank you, Belinda. So I'm Peter O'Connor. This is my colleague, Dr. Jain. And what we were going to be talking about today is the issue of enhancing early diagnosis and culturally sensitive support and care for patients with dementia. So before we start, there are a few acknowledgements I'd like to make. First of all, it's our pleasure to present something here at the Quality Forum. And we had a number of collaborators and partners that I must extend our appreciation to. Firstly, the UBC CPD group. Secondly, some of the family practice divisions of Fraser Health, in particular the Langley, the Surrey North Delta, and the Peace Arch White Rock. Also to Fraser Health itself, which provided administrative and secretarial support. And then to a number of other organizations such as the Alzheimer's Society and the ICON group. So moving on to the next slide.
We need technical support. Can you advance the slide for us?
Okay, so just, and of course one other major acknowledgement, which is the Specialist Services Committee. Through an application for grant process, we were selected to proceed forward with this project. Now that Dr. Jain or I have any affiliation to declare, and so I'll hand it over to Dr. Jain for the next portion.
Thank you, Dr. O'Connor. Next slide, please. And the next one. Can I have the next one, please? Thank you. So first of all, let's start by talking about dementia. Dementia, as we all know, it's a very complex disease requiring multifaceted, interdisciplinary approach involving a range of healthcare professionals, specialists, and primary care people. It cannot be done alone. The challenges of diagnosing and supporting people with dementia and their families and caregivers are expected to increase, as we all know, and this is phenomenal. The challenge is further compounded by the Fraser Health's large different communities. We know Canada is multicultural, and we focused on one community, which was large South Asian community, who may be at greater risk due to increased prevalence of the disease, due to the stigma, and also the fact that ethnically, cardiovascular risk factors are higher, the blood vessels are narrower, and there's more chances of Alzheimer's and vascular dementia. Next one, please. Okay. Oh, great, we're good. So what are the gaps in dementia care? Evidence suggests that dementia, especially in early stages, remains underdetected, underdiagnosed, underdisclosed, and undertreated. This may be magnified, especially in South Asian community, due to the cultural context, perceptions, knowledge of aging and dementia, stigma, and access to culturally sensitive resources. Many primary healthcare practitioners report a lack of confidence and the skills required to provide a diagnosis of dementia, and we found that out by a needs assessment survey that we did in 3 communities. Educational and interdisciplinary consultation support from specialists such as geriatricians, geriatric psychiatrists, and neurologists have the potential to support improvements in early diagnosis, and that's what we found out in the course of our project. Why early diagnosis? Why is it so important to pick it up early? Because receiving an early diagnosis of dementia will result in earlier treatment, which is proven to be more effective for maintaining life, gain earlier access to dementia information, support and services, and allow time to plan for the future. Moreover, there are certain conditions such as vitamin B12 deficiency, thyroid, like hypothyroidism, depression, among others, which may present as early dementia. And if they're picked up in time and treated in time, you can actually improve the cognition and the function. And it should be diagnosed as early as possible. Now I'm going to give the podium to Dr. O'Connor, and he will walk you through the dementia strategy.
So continuing with our tag team approach. So let me get my page updated here. So based on some of those background issues and gaps, we decided we'd go ahead with putting in a proposal that would allow us to improve this issue of early dementia diagnosis and management. And we thought we'd approach this from a 3-stream direction. Firstly, the one that you see on the left-hand side there, which was the development of an integrated interprofessional collaborative practice guideline or pathway. We drew together family practice groups, specialists, interdisciplinary groups, pharmacists to help, and modelling it on the BC dementia guidelines, drew up a pathway that we would then road test or field test in the next box you can see there, which was a competency-based dementia education program, which was a mentor-mentee 3-to-1 ratio of family practice to specialists working collaboratively over a period of 8 months. And finally, the culturally sensitive component of it, which Dr. Jain will describe later. So if we move on to the next slide, you can see, well, you probably can't see actually, but you're supposed to be able to see up in the top left there, which is an example of the pathway. And it is being developed as a drop-down interactive PDF, which initially would sit on the desktop with just 7 or 8 headings. Then you can click on each heading and click further down into each heading to get practical steps as to what you would do next in the process of diagnosing and disclosing this diagnosis. The interactive PDF can be and has been uploaded to various EMRs, and we use the education mentoring as a pilot testing of this. The outcomes that we got were encouraging, and which was that the majority of the mentees or the family practitioners in the education program both used the collaborative pathway and found it useful. From the very get-go, they were keen that we would integrate it into their EMRs, and these were the 3 EMRs that this particular group of family practitioners used. The final milestones in the project were to, after following that period of 8-month review of the pathway, finalise it, get it up onto both, have it as a PDF document that could appear on an individual desktop, but also available through 3 EMRs, both MedAccess and Oscar, and the profile planning is ongoing. We're also offering ongoing education on this to the other family practice divisions in Fraser Health. Now, the mentoring program, they involved a group of 8 specialists, family geriatricians, geriatric psychiatry, neurologists, working closely with 24 family practitioners in the different divisions. This was an 8-month monthly meeting, either face-to-face or Skype meeting format, discussing cases within the family practitioners' group of cases, or we also had some mock or trial cases available if there was no actual clinical case available. The results that we have got from that were that 95% of the primary care physicians who were in the program felt that they had been positively affected by the education. They were more easily able to recognize dementia early on. They had a more planned approach to what really in a family practice environment is a multi-step process to achieve the diagnosis and increase confidence in using tools such as SMMSE and MOCA. I don't know if any of you have ever read the instructions for MOCA, but they stretch like about 3 pages and they're extremely explicit about don't do it this way and do it that way. And I think a lot of people bypass the 3 pages. And then we have 86% of the specialists felt that because this is meant to be a mutually interactive and beneficial process for both specialists and family practitioners, and the specialists felt that they also gained significantly in terms of better referral practice. Some of the testimonials are there, you can read those. So on to our third arm, and we just let Dr. Jain retake the podium, and we're
Thank you. So I'm going to brief you regarding the third arm of the project, which was culturally sensitive program. So what we did was a needs assessment survey out of patients from some clinics, community, as well as random picks were taken from temples. So we found out what was the missing link, and we recognized a lot of gaps. One was the language barrier, second, cultural barrier, third, there were no language and culturally specific resources. The interesting part we found was in Alzheimer's Society, especially in North Delta area where maximum South Asian population is, there was nobody in Alzheimer's Society who could speak the language or actually know the culture. So then we decided to work on this aspect, and these were the milestones we achieved. The Alzheimer's Society of BC has committed to sustaining the Punjabi speaking South Asian support and education coordinator. Now there is a support and education coordinator that patients can call. And we developed something called Punjabi MOCA, as Peter was talking about MOCA, but we went a step further. We had a Punjabi MOCA, but we made the instructions for the non-Punjabi speaking family physicians or anybody else who's involved in the care to follow in Pinglish. That's my word, but Punjabi English. So I actually translated the Punjabi into Pinglish so that you can walk through it easily, and I can help. And then I gave free webinars about that. And when we did the needs assessment survey, we saw the paucity of knowledge from the patient's perspective, and they wanted one-on-one. So we asked them, what was the media you want us to use to talk to you? So they said the top choices were one-on-one education, radio and newspapers, and that's what we did. We took out newspaper articles, we did multiple one-on-one educations. So these are the culturally sensitive things we did. We translated we made 7 numbers for early dementia. I have some pamphlets here with me, which I can show at the end. So Keep Your Brain Healthy brochure that was translated in Punjabi, English, as well as in Hindi. Handy Dart, we made simplified versions of it so that they could actually fill the forms without going through a roller coaster. And we took out a book called Getting to Know Dementia. It was already there on Fraser Health website. We actually revised the booklet to make it more culturally specific and sensitive and easy to read. And these have been actually uploaded on the Fraser Health website, Punjabi MOCA and Dementia Pathway. So there was public awareness campaign after that, and I just wore this scarf to show it was me. just joking. So then, next slide, please. So there was news release, and there were multiple interviews and newspaper articles. So we tried to spread the word across in the last year of the project so that maximum people become aware and don't find it's a stigma. Please embrace that there's a problem, and please and go to the family doctor soonest possible in the earlier stages, because that's when we can make a difference, and it's all about quality of life. So that was emphasized time and again. So next one. So there was a big public awareness campaign, dementia workshop at the temple, and ICON was a partner. ICON is from UBC, CBD. They do culturally sensitive talks, so I partnered with them. And Alzheimer's Society, I partnered with them and did some talks for education. There was a poster was displayed in Geriatric Service Conference as well. And we also, again, had a public awareness campaign, which was attended by over 500 people, almost done. So the results post-talk survey. Peter, the next one. Yeah, please.
Okay.
Yeah, that's one. So this is what I wanted to tell you, that at the end of the survey, at the end of the talks, these were the results, which were very, very encouraging. 97% had understood that they should talk to the doctor. And this is huge, because now I get actually patients who say, oh, I saw your talk and I saw your poster, and I want to know, do I have dementia, or does my father have dementia, because he's showing those signs? And that's huge in our community, to remove that stigma and to come forward. So I think we've achieved something. So, and the lessons learned and success strategy that we figured out was to engage the target audience in the design and development of the project. It always goes far. Mentorship model can work, as we saw, 1:3 ratio. That was really very, very well appreciated, and it was mutual learning. And the culturally sensitive public talks one-on-one always goes a long way. Thank you so much.
Thank you.
Thank you. Please stay up here because we have some time for questions. I just want to say how impressed I am that your engagement of the community, but also with your partners in that project. So, questions? We have some comments that they want to share. Anybody want to say, woohoo, well done? That was good. Very good. So we'll have some time. Will you be around after as well? If people.
I might have to.
Okay. So if you have a question for Dr. Jain, you might want to ask it now. Yes.
Were you just focusing on Alzheimer's or dementia through vascular dementia and other forms?
That's a
Can you
good
repeat the
question.
question?
No,
Yeah, repeat it.
yeah, that's a good question. We were focusing on dementia in general, but there was so much of paucity of information. Like, we had to start from ground level. What is dementia? What is the difference between Alzheimer's and that? Because the people, when they came up to us, they didn't know what, if it is dementia. In my culture, there's a term called satyagraha. Everybody who turns 60 has to lose their marbles. That's what they think. So seriously, so at least coming from that level to the level that they're recognizing there's a problem. And then it was up to the geriatricians or primary care physicians to look into it deeper, which form of dementia it was. The biggest hurdle was to just get there. So we did educate them about all types of dementia, very briefly introduced them to the types of dementia, even in the booklet, the Getting to Know Dementia. We did mention the various type and what is Lewy body dementia associated with Parkinson's, so subtle things so that they are aware there are other types of dementia. So when they ask me, I tell them dementia is like colors. And this is something that they relate to very well. I mean, all my patients, irrespective of the culture or the background, I say that it's like colors. Colors are red, blue, green, yellow, orange. Similarly, dementia is of various types. So if you say red is Alzheimer's, this is the biggest that we see, 60 to 70%. And then over the age of 85, every second or third person, they say, is likely to have that. So the commonest we see is red, but there can be blue color, which is, maybe Lewy body, vascular. There could be a mix of the two colors, too. So this is how I explain it to them, and then they relate to it easier.
Like, from the physician's side, the actual collaborative pathway goes into a fair bit of detail in that section of diagnosis, clinical signs to look for, symptoms to look for, the idea of when a patient might be referred to a specialist if they seem unusual compared to, a regular case of Alzheimer's, if there's any such thing, and so the pathway for physicians goes into a lot more detail in that, obviously, than the kind of patient education. Yeah.
Thank you. Any other questions? Yes, there's one there and then up there.
I don't know how to ask this question, but I'll just make a comment. My father was, he ended up being diagnosed with dementia, but at the very beginning, he knew something was wrong. We knew something was a little bit off. We went to the doctor, and just as the doctor was saying, well, based on their culture, it's like he's going into his second childhood. That's just natural. It's part of life. What do you do? How do you, in case other families have to go through this type of stuff?
Well, I'll let Dr. Jain try and answer that as well. I think my response would be that was part of why we were trying to educate the physicians and working collaboratively between primary care and specialists. I see wrong diagnoses on both sides of the fence here. I see patients who do not have dementia and maybe somewhat forgetful labeled as having dementia, and I think that's one of the more major errors you can actually make, which is tell someone they have dementia when they don't. And I also see the opposite side of things, where people clearly have had dementia for several years and it hasn't been picked up on. And regardless of whether the medical treatments are effective or not, there are useful things that can be done in that first couple of years. And so I think a lot of that is education of the public in terms of the better questions to ask the family doctor, so that they're in a position to maybe challenge the authority of the physician on this one. Are you saying it's just aging? Are you saying it's not dementia? But also gearing up the physicians to be better able to make that accurate estimation. I don't know if you want to add to that question.
So, yeah, very appropriately put, and this is the challenge we see day in and day out, So from our side, this is why we tried to make that comprehensive, all-encompassing pathway for family physicians or primary physicians or anybody who's involved in dementia care to look at. And in that pathway, we actually put, in terms of history, what are the questions that you should be asking? What is it that you should be looking for? And what should point to the diagnosis, where to go from there, so that it's not difficult for them to understand. So from our side, we are trying to increase the level of education awareness outside in the physician sector or people who are involved with dementia care. But from the patient's perspective, I would say don't let go. Like, if you know that there's something wrong, just don't take no for an answer. This is what I would do.
Thank you. I'm just going to check if we have time for one more. We have time for one more question. Okay. Thank you.
This question for Dr. Jain, and I wonder, when you developed the pathway, did you have opportunity to engage patients and families to develop that pathway? What might be some of the greatest challenge to have them involved?
Yeah, thank you for your question. This pathway actually is quite technical. It is at the level of when a patient, so there were 3 arms to the project. One is development of the pathway for the primary care physicians and the nurse practitioners. So it was for people who, when patients come to them, how to impart the diagnosis of early dementia or provide dementia care in an all-encompassing, comprehensive time, cost-effective and time-effective way, so that you can just go through the checklist for you. So this was the education for the people who are taking care of patients. So the second arm was education, mentorship between the specialists, like geriatricians and geriatric psychiatrists, with the primary care physicians in a small cohort, like 3 primary care physicians to 1 specialist, to talk about the pathway, educate about the pathway, and the need to provide dementia care. So this is education of the medical professionals. And the third arm was specifically done in South Asian community because of the paucity of education. So that arm was separate. So in that arm, we realized we are starting from scratch, like ground zero. So we did involve patient and caregivers as far as Alzheimer's Society was concerned. We did involve them in their needs assessment to do to see how we can impart education to them. But making a pathway was too much to ask from them at that point.
But we did have the Alzheimer's Society corresponding on the contents of the pathway and some of the kind of typical questions you might ask. And so we did get, indirectly, I guess, get some patient or population level input into that. Yeah.
Thank you, and that takes us to time. Thank you so much for your presentation. Thank you. I'd like to welcome up Marija Stefic-Cubic. She is a clinical nurse specialist of surgery with Providence Health, and this is presentation Frail Elderly Preoperative Assessment Clinic, from an idea to a reality.
Thank you, everyone. I just want to say that this, since August of last year, we have a preoperative assessment clinic at St. Paul's Hospital for Providence Healthcare that I'm very proud of, and it was lots of work to set it up. But to be honest, I'm not doing any work right now. Geriatric team does everything. So, and just to this, I don't have anything to disclose. I don't have any conflict of interest with this presentation. And the journey started way before I actually joined the surgery, but it was quite a challenge to get everything working and to engage all teams that need to be involved within the project. And when we finally got the team together, so we got our geriatric teams and our Department of Surgery working together to make it possible. So we look into current status and what are the patients that we actually serve, and over the last 2 decades, the number of seniors that are going for surgery is rapidly increasing, especially the seniors that are over the age of 80, and we are seeing more and more patients that are over the age of 90 going for surgery. And I'm sure every single one of you that works with geriatric patients, if they come sometimes to the unit and saw the patient and thought, oh my God, what they were thinking. They did this to this person? Or did they really know that what they were signing in for? Was someone explaining what they were going in for? And that was kind of where we thought that including frailty would be a very important part of our preoperative assessment. So we know that they are at increased risk for adverse event, but we also know that they sail through surgery, some of them very well. You cannot base it on age only. And they are at a very high risk for impaired function, quality of life, and not just morbidity. And if we use the frailty tool, we can complement preoperative assessment, current preoperative assessment, and also assess their patient status at home and in a community, how they are doing. And what are their goals? You know, if surgery will give them 6 months and no surgery would also give them 6 months, will they sign up for that before going ahead with the surgery? And so we also look into our database, and frail elderly are at higher risk for postoperative complication, including delirium, SSI, UTI. Many stay in hospital longer. We look actually into our NISQIC database. We are fortunate that we have a data, we collect data since 2011. We are one of the early adopters. And we also collect data on some of our procedure for all patients, not a random samples. So for example, our colorectal group of patients, we review every single case. And then we know also that those discharges are very complex, some of them, to get them home from hospital, and many don't even make it home. Some of them go to the long-term care facility. So how does our preoperative assessment looks like currently? They are usually seen if we are lucky, 10 days before surgery, and there's very limited access for the allied team members, but also preoperative assessment is very, very challenging for patients, especially for seniors. If they have to learn how to do the ostomy care, like what the expectations are, and that takes about 2 hours. And really clamping everything at the one appointment, it's very difficult, and I cannot remember everything that people would tell me in that one setup. And also, the pre-admission clinic has very limited, almost no access to any allied team members. There is no access to social worker, OT, PT, and its focus is on end organ compromise, not on a function and mobility or quality of life, patients' goals. So when we started the project, we chose our colorectal group, not because they have the highest number of seniors, but because they have the lowest, and we thought if we can make it for the process work, so then we can actually expand to all of the other surgeries. And the other reason why we chose the colorectal group, because these are mostly our cancer patients. So as you know, if you try to get a specialist appointment, it's 6 to 9 months if you're lucky. So we thought if we can make it our patients that wait for surgery 28 days, seen on timely basis, so then everything else will be like a slow motion picture, you know, we can make it that. And also one important thing that is our organizational focus is to include the goals of care, patients' goals of care in the assessment as well. So the action plan has simple 4 steps. So understand the current preoperative process, create the frailty screening tool and process, create the feedback referral process, and then test the system. We use lots of PDSA cycle. Oh my God, so many. As a preoperative process assessment, I looked into a review surgeon priority assessment tool and map out the patient journey, preoperative journey. And with the assessment tool, there are certain type of cancer that we actually really rush. And the idea was, as I said, if we can see them soon, how can we get that specialist assessment without waiting 9 months? And at St. Paul's Hospital, we are lucky we have a geriatric consult team. And so we engaged the geriatric consult team because they were not stuck in a clinic and also did not look after inpatients. So they were kind of more mobile to look at those patients for us and pre-assess them. And then patient journey. As you see, from the time the referral is received to the surgeon's office, usually takes 7 to 10 days until patient gets the consult appointment. And from that time, it takes about another 7 to 10 days until they get a pre-admission clinic appointment. And a pre-admission clinic, often we serve lots of cancer site. We are colorectal site for the province. So we see many patients from outside of Vancouver coastal area, and some of them just come on day before surgery. So it's very, very limited time that we can make any impact. So the time to actually engage a geriatric or any other allied team member to help us out, assess and optimize that patient is actually from the decision, from the time the decision of the surgery is made up to before the pre-admission clinic assessment. So that when they come to the pre-admission clinic, they will be all tuned up and ready to go. So we look into geriatric with geriatric team into geriatric frailty screening tools. There are so many validated tools, and I kind of got a huge list to review from our geriatric team. And with every single one, we actually missed 1 or 2 components. So we thought, okay, why can we not just create a screening tool based on the information that we had? And one of the common document that every single surgeon at our site uses and has to use is patient healthcare questionnaire, and it's part of the OR booking package. So their booking package will not be reviewed unless they send. So I thought, okay, this is the document that we need to change and improve and include the other important questions that we can get some information and build the tool. And this is what actually Marta Spencer, Dr. Marta Spencer and Jocelyn Chase helped me create. And have a screening tool based on our healthcare questionnaire and the scoring, and have a score for the surgeons. Geriatric frailty score of 3. Maybe we should think about the geriatrician consult when they see the patient in their offices. At the same time, our organization actually uses electronic healthcare questionnaire, and we had a company, the new Hippo, that is done through, and that was done way before we were even starting to work on this project. So we just thought, okay, let's just try to build this and have a scoring done automatically for those patient electronic version, which is really saving time for everyone. And the frailty score shows for the surgeon even before the patient comes to their office. They already know that they are dealing with a frail person. So the other thing that needed to happen was not something with our Department of Surgery. It was changing the elder care referral form to incorporate preoperative assessment, and they are done, and also education for MOA. Our surgeons are all over the city, so all this had to be distributed to all of the offices, and they had to build into their electronic system so they can easily refer, because patients are not necessarily seen, actually minority of patients are seen at the site. So the PDSA cycle, so as I said, there were many. I actually just put some lessons learned from each one of them and how things change during the process. So the first, as I said, the geriatric consult team was seeing the patients, and I was running around and trying to find a space where the patient's going to be seeing, how they're going to register, where they're going to dictate, who is going to get the information. So, and you know what? The one thing that we totally overlooked was how long it takes to get the patients on a phone. No one is answering the phones these days. So it takes so much time like I did not appreciate the work that people are doing trying to reach the patients to come for the visit. So, and with that, we kind of thought, okay, maybe if the patients are warned in a surgeon's office, then they will anticipate the call, so it will cut down our time, not just allow them extra time, but also see how that's going to work. And it actually did improve the time for the calling the patient out and scheduling them to come for the geriatric assessment. But then from the geriatric team, we got a feedback. The outpatient clinic is not the best place for them to see the patient because they didn't have access to their own services. For many, or there are some of you are from St. Paul's, but many are not. So we actually have a very good elder care clinic at the St. Paul Hospital, and we have access to social worker, physiotherapist, dietitian, occupational therapist. So while they were seeing patients in an outpatient clinic, it's set up mostly for surgeons. So they didn't have access to allied team members. So it was really challenging. So the next thing we thought, because we had two patients actually that need to be seen with the cancer, new diagnosis of the rectal cancer. One was 87, the other one was 91, and they need to go for surgery very quickly because they were bleeding. So we thought, oh, how about if we can add two instead of one patient to the geriatric team to see on our pediatric. So, and the feedback that got back from the geriatric team was like 2 patients are too much for the person that holds a pager, because like geriatric assessment takes the time. It's about 1.5 hours to 2 hours. And if there is a translator involved, cognitive impairment involved, it takes even longer. So it wasn't as easy as it looked. But by that time, actually, the geriatric team were going through some reorganization, and they said, well, why don't we just bring the patient to our clinic? And and that was very positive experience. And at that point, actually, the ball started rolling, and everyone was on board and engaged. And we have our clinic that offers comprehensive geriatric assessment that addresses the issue that arise from the frailty. Also, they do the prehabilitation in elder care. As I said, they have falls and balance clinic. They have a dietitian. They have a social worker. So lots of things have been organized for those patients that are coming for surgery. And the best thing for surgeon is that actually those patients that are seen in a pre-admission clinic are followed by geriatrics team post-operatively. And as you probably, everyone who is working in acute care knows, the surgeons are in OR. So if there's a delirium, or if there's anything else that's going on with that senior patient post-op, so having that support is such a benefit for us and for our team. So next steps, as I said, we started with the colorectal group, and then by September we expanded the same service to all gen surgery and vascular surgery at St. Paul's Hospital. And currently we are working now to our bigger group, which is our ortho patients. And that would be probably the most impactful, because this is the group of patients that actually wait for surgery about 26 weeks or longer. So there will be really meaningful changes can be done for those patients before they come for surgery. And also, we do, at our site, do lots of gynae and urogynae, which is pelvic floor repair. That means the elderly women. It's different than some other sites. So our gynecologists and urogynecologists are coming on board slowly. It depends on, of course, those that are doing the OB-GYN and C-section. They are not as keen to look into that. But and so these are the people that actually make it happen. So and allowed. The one thing that we are all very proud about our project is that we didn't spend any money. We just used the resources that we have, and as I said, we are fortunate to have those resources at St. Paul's Hospital, and I know that might not be the same for everyone else. Also, there were so many people that put up with me coming around. Can I have this room? Can I have this room? Can we do this? So Jeanette Cooper probably doesn't want to see me or hear me for for a little time. So I'm going to give you a break until another project. But also the geriatric team as well, and our ERAS committee, and I have my teammates here with me today to support me through this presentation.
Thank you so much, Marija. That's healthcare in a nutshell. Do amazing things, but with no money, right? That's great. And I wonder, with all the support that you're giving, how long before you welcome your 100-year-old patient into surgical?
Oh,
Have you had one already?
No, not yet, but we had 96-year-old.
Yeah.
96-year-old coming, and that was actually very good collaboration with the geriatric team. Was a 96-year-old, came rectal cancer, decided to go for surgery because he's looking after his elderly wife that doesn't speak any English, and and it actually was discharged home, did well. It stayed in a hospital a little bit longer. The delirium was a little bit challenged, but as I said, we had the geriatric team to support us through, and he did go home to look after his wife. So
that's amazing. That's incredible. Any questions for Marija? Or just another woohoo? Good job. Thank you. And are you able to stay around if people have questions? Okay, thank you so much. So our last presentation is #unit goals, building a dementia-friendly culture in hospital. And we have Marta Filipski, who's a patient services manager and hospitalist medicine and specialized dementia program at Vancouver Coastal Health, Jennifer Tabamo, clinical nurse specialist at VCH, and Koren Jaschke, who's a rehabilitation assistant also at VCH. So welcome.
Okay, great. We're all good to go. Wonderful. Well, thank you for having us, everyone. We're thrilled to be here and share some of the work that our specialized dementia unit did in its creation and sort of where we're going from here. So I'll just start off that we're not able to identify any potential conflicts of interest, but I would be remiss to not disclose all of the passion and energy that our working groups and folks that were involved in this work brought to the work. The incredible support that we received from the organization, as well as our UBC and VGH Foundation, and the incredible team that works on this unit and supports our elders and our caregivers and our patients and families every single day. So to start, so we'll be kind of talking about this unit that we developed and the work that kind of went into it. Our previous presenters sent some really good context around the need to support this population. This project occurred in a bit of a broader context. We were looking at our 4 hospitalist medicine units that were structured in a subacute acute model. And we were kind of taking a look to see, is that the most efficient use of our resources and the way that care and patients flow? There was a lot of transfers between units, a lot of kind of issues around continuity of care. And so when we took a look, we created a 3 units that were acute hospitalist medicine that had both subacute as well as acute patients. But we also recognized that there was a specialized population, our dementia patients, that were lost in this shuffle. So they were across all 4 of our units. Many were some of the more aggressive patients or confused patients where we would end up spending a lot of time having one-to-one resources with them. They were getting lost in the shuffle. So when we kind of moved forward with our redesign, we developed a unit that was specialized for this particular population. So in this population, what we noticed, we had lots of long lengths of stay. So that's always something for hospital administrators that's on their mind around long lengths of stay, high ALC rates. Looking for alternate levels of care, looking for where we could discharge our patients. Like I mentioned, we had violence and aggression on the units, as well as a lot of movement between locked units, unlocked units, and where's the best place for our patients. So our aim was to create this specialized unit that had both grounding in best practices, but looked at reducing environmental barriers, developing staff expertise in this population, improving psychosocial therapies, and including caregivers and family in their care. So we started with the patient journey. So being students of quality improvement, we worked with staff, we worked with patients, we worked with caregivers to understand their experience in acute care settings, and looked at ways that we could do better. So we are a 19-bed unit just across the bridge in one of the penthouses at Vancouver General Hospital. So you'll find us 19 beds. Sometimes we do go over capacity or into surge. In terms of who we serve, so we admit behaviorally challenging patients with acute illnesses and complex psychosocial situations directly from the emergency department. We do sometimes take transfers from other units. However, it is at the discretion of our charge nurses. Our patients are generally over 70. They have dementia and difficult behavioral or psychological symptoms of dementia, and very unresponsive behaviors are common. So we're okay with verbal, physical aggression, exit-seeking, severe paranoia. That's our expertise. Our goal is to make sure that at least 70% of our patients meet this criteria. Being in an acute care setting, patient flow is often challenging, so sometimes we do bring in other patients that may not meet this criteria. I'm proud to report that generally we're closer to the 100% than the 70%, but when we do look at who else we bring onto the unit, we make sure that patients younger than 50, we would exclude generally, so we'll look at the patients 50 to 70, but make sure that we're not creating more vulnerability on the unit by excluding patients that might come in with alcohol withdrawal or complex pain and addiction issues. Okay, so I'm not sure if many of you have spent long periods of time in an acute care environment, but when you do spend time in an acute care environment, that you'll quickly notice it's loud, it's bright, there's a lot of moving pieces, parts, people, equipment, and so one of the things that we knew that was sort of a trigger as well as not the best place for our dementia patients was this type of environment. So we tried to look and ask what would be the best, what are some of the best practices around supporting our patients from an environmental perspective. So we focused on 4 areas, so improving orientation and wayfinding, and I'll show you some pictures in just a little bit. So we looked at colors in the hallways to look at, so I guess also if you spend a little time in acute care environments, you'll notice every single room is the same. So, if you can figure out the number and figure out where the labeling is, you'll know where to go, but every room, every hallway sort of looks the same. So we looked at improving orientation and wayfinding. We looked at ways that we could improve staff efficiency on the actual unit from a physical perspective, looking at ways to improve comfort and reduce anxiety and promote function, and improve patient safety. So this was our hallway before. You can see it's very common, lots of equipment, lots of supplies everywhere. So what we did is we looked at painting for wayfinding. So now we can say to our patients, oh, your room is just down the blue hallway or down the green hallway. It was a simple fix, though if you worked with hospital facilities before, it wasn't quite as simple as we thought. But that was kind of the first step. The other piece in terms of wayfinding that you can't quite see in these pictures, we've got big room numbers. So our room numbers before were very long, very small. We've got really big letters right now, so a patient can identify. We can point them to the room where they are. We also decluttered quite a bit. So we had our team really focus on ways of making their life, their work easier through decluttering. So in the before, you notice we had tons of wheelchairs, brodas, supplies. When the team was done, they cleared those hallways. So they found homes for equipment in different places. They reduced the amount of equipment. So talk a little bit about in our success factors, the reduced use of brodas, and found ways to remove some equipment that potentially could have caused a violence risk as well, or been a safety concern for some of our patients and staff. We looked at doors. So we found a lot of the triggers for patients was not being able to leave the unit. It is a locked unit. And some of our violent incidents, when we looked at kind of where things were happening, were actually at the front door. So we even had one incident that I remember, a patient smashing through a window with a cane, just out of sheer frustration of not being able to leave. So we looked at ways that worked with fire code that we could hide and mask the doors. So this is the and on the right-hand side, you'll see one of our doors. And this is the back door. So this is the door which is often open when staff are coming in and out. And we were able to mask these doors so that it creates that environment that it doesn't trigger patients as much. We created an activity room, so staff gave up their staff lounge, but recognized that a space for a calming space for patients, both from just having a place to sort of relax, hang out that's not in your hospital room. There's dimmed lights, calm painting, just to create kind of that really quiet environment if needed. As well, this is a place where many of our activities occur, and Koren will talk a little bit about that in just a second. We're often asked, how do we monitor who's in the room from a patient safety perspective? We're pretty low tech. We've got a baby monitor at the nursing station just to keep an eye on folks that are in the room, just so we know who's there. Okay, I'm gonna hand it over to Deb.
Thanks so much, Marta. And my name is Jennifer, and I'm the clinical nurse specialist for medicine program. And part of the work, not just exploring the physical environment, was to also look at the clinical environment. That means looking at our tools, our processes to facilitate care planning. The first thing that, to the other side. The first thing that we did was to actually look at how we round on our patients. It's what we call the eye care or interdisciplinary care team rounds. Usually we include all of the allied health team, including the physicians and nurse leaders in the discussion, as well as discharge planning. But in this new model, we have integrated our geriatric psychiatrists, as well as clinical nurse specialists during the rounding. Really the access to the expertise, the immediate follow-up and feedback, and just probably like a quick advice and consult for these vulnerable patients is very valuable. Timely. We used to really contact our specialists, and they're scattered all over the hospital, and that's what we know, right? But nowadays, we are very happy that we have their immediate access to their expertise around this a very important care planning discussion. When we talk to our staff and approach them around dementia care, they told us they feel very stressed, almost on a daily basis. They didn't know how to care for patients with dementia in an acute care setting, and yet we expect them to be skilled and be able to deliver that person-centered care. Dr. Lillian Hung is here as my partner, and we both introduced in 2016 the Gentle Persuasive Approaches to Dementia Care Education Program. It's a Canadian evidence-based program. It's practice-based, and it really opened our eyes into putting person-centered care at the forefront of an acute care hospital or an acute care unit. We have done a lot of focus groups and staff interviews to capture their baseline information and practices. And what we found is that only 17% of about 112 learners told us that they had formal education on dementia. So that was very powerful for us, right? And originally, the GPA to Dementia Care Program was intended for long-term care staff. But nowadays, more and more acute care settings are embracing, and we're proud to say that we're one of them. The medicine program and the hospitalist and the specialized dementia care program are one of the acute care units that embrace this. Care planning huddles. What do we mean by that, right? Where do we find the time to actually make the care plans? So what we've done is to actually introduce a weekly care planning huddles into this acute care unit. It is part of our knowledge translation strategy and facilitate the uptake of knowledge from the GPA education. So these huddles are integral to actually promote, the personhood in the patients that we care for. This is open to any point of care staff caring and interacting in our units. We have nursing staff, RNs, LPNs, we have care aides, we have unit clerks who are actually right in front of the unit and having to witness some of those distressing symptoms regularly. We have nursing students, we have physicians as well who join us in these very important discussions. We usually talk about two patients, one who's newly admitted, quite unstable, quite complex, and really having a difficult time transitioning into the unit. And we talk about another patient, a patient who's been with us, but still having a hard time with the transition process and still having unsettled responsive behaviors. This is really where we talk about the stop-and-go approaches that we learn in GPA. And as Rona Flynn this morning talked about, minimizing the hurry-up syndrome, right? Like in terms of dementia care. I think it's very powerful when you talk about that because you have to stop, slow down to actually move forward in dementia care and not be the source of the distress and stress for both patient and the team. Yes, we have a recreation therapist in acute care. We're very proud to have received generous funding for 3 years of recreational therapists. Our patients are watching those doors. They're very distressed with the banging of the opening and closing. We now have a key allied health team who's helping us in the care planning process of our patients being in a place that's unfamiliar for them. And she has joined us in our eye care rounds as well as the care planning huddles as well. She now expanded her role, not just in the specialized dementia care unit, but all across the 4 hospitalist medicine program. And during the care planning huddles, what's the framework? How do we do that? We have introduced some of the clinical tools that are really validated and to make sure that we are speaking the same language across dementia care. Some of you may be familiar about the DOS tool. It's a very easy tool. We used to didn't know about DOS, and yet we were all taking care of patients with dementia for years. We didn't know about this. A nurse or a care aide can fill this out. It's very easy. It's really a behavioral pattern tracking tool and a sleep log to make sense of the information that's happening in the unit, just so we can support where the most critical period of times for the responsive behaviors are happening. And you mentioned, Marija, about delirium and frailty earlier. We have to revamp our care planning tools from the delirium perspective as well. I used to talk to staff, and they're caring for highly delirious patients, and they said, "What's CAM?" Right? I'm like, wow. I'm like, at the point of care, they are right there, and they don't know what CAM is. And yet, they are caring for highly delirious patients. Typically, our patients are coming from the emergency department, highly complex with underlying acute illness, and they're quite delirious. That's what we promote. Think delirium first. Is this an acute change? Because don't just assume that it's related to dementia. PRISME is the framework that we use for care planning. It's for prevention, management, and treatment of the underlying cause or contributory cause of delirium. And lastly, the This Is Me tool. This Is Me tool, we have introduced this into the units. It's a 1-page document, an adaptation from the Alzheimer's Society of Canada's All About Me. We have also engaged Keen and patient advisor in simplifying this tool, making sure it's using plain language. We give this to the patient's family or care partners so that we can better know who the person is behind the disease. Sometimes it's very hard to figure out who they are, what they'd like, how they want to talk, maybe Pinglish, or Taglish in my culture, we call that too. So those are little things, but they matter. Very important information that in an acute setting, it's so hard to find and dig. And so finally, this is the care plan tool that we develop. I know it's quite worthy, it's personalized, it's tailored, it's a living document that we integrate all the information that we learn about the patient. It's really very helpful, especially when we transition our patients to long-term care facilities, for example, or tertiary mental health, so that we can promote continuity of care. And I will pass on the floor to Koren.
Great. So I'm just going to talk to you a little bit about our programs that we have on our unit. This is our activity calendar. It's a monthly calendar. It shows patients, family members, and staff what we have to offer on the unit for the patients. We have 2 very popular programs that we offer. Our gentle exercise class with support from our volunteer Arena, she's at the top there, and also our activity group, which is supported by Zoe here, our other volunteer. So our volunteer program also includes our teen volunteers. Here we have Gyro, did I say right? Gyro playing piano and Costa playing cello. And all of our volunteers come in regularly, and this plus staff involvement really is strongly supports our sustainability of these groups. This is one of our favorite, well, I mean, we like them all, but this is one of our volunteers. This is Huff. And Huff comes every other week, and I just see patients' faces light up when they see him, and they get to offer him a treat. He comes to a group that we put on there, and he also does one-to-one throughout the unit. If people want him to come into their room, then he does. And it's just wonderful to see the engagement between the dog and patients and family members too. So let's see, do we have, yeah, next one. This is our staff Zumba. On the weekends we have this on. The staff get up, they do the program. It is great for their fitness, their wellness, and it also helps to distract a little bit from maybe exit-seeking patients. They're like, wow, what's going on here? It's all movement. And they're even going to get T-shirts. I think I don't know if they have them yet, but they're like a big team. So I think it's really great. And the timing of the day that they do it is usually around later afternoon, where possibly some patients are sundowning. So it can be very helpful, a distraction. And is that it? Oh, and then these are just some of the pictures. We play music. We do seasonal groups. You can see Huff there just staring at that cookie. He's hoping. And sometimes he gets it. And someone drawing. And so it's wonderful having this room. What I wanted to say is having a dedicated space to run these programs and to have space for people to dine together or have a quiet space with their family member is amazing. It's been great. Before on the other units, it's been very stressful when they're all up at the front. They're stressed. There's so much going on. And now there's quiet places. We can watch them also down the hallways. We showed you how clear it was. Now we've got quite a few spots, like at least 4 spots where patients and family members can go down the hall and sit, have a quiet moment, and still be seen and still feel like they're away from their room and away from other people sometimes. So it's been great. And I just really want to thank, there's some of the staff here, but I really want to thank all their hard work and caring, doing all this quality improvement. You guys are amazing. Yeah, incredible teamwork on the unit. And the other units too, the other hospital units too, yeah. Thank you.
All right, so I know we're nearing time, so we'll breeze through sort of this piece. Just to point out that this is not a one-time thing. You can't slap a sign on a door and say this is now the specialized dementia unit and away we go. So there's continuous improvement. Oops. Slide, please. No, it's not. No? We'll just get the slide. Advance the slide. So we are part of our hospital-wide TBQI quality improvement program. So staff come together, have dedicated time to focus on quality improvement, and frontline staff are encouraged to participate. So we're just going to quickly highlight some of the pieces that we've done. Slide, please. There's a wonderful storyboard, I think just outside the door, about our protected meal time, and Jobin, our dietitian, has been working on this around supporting dedicated time that patients are undistracted and can focus on feeding. Slide, please. Our candle project. So this is around supporting staff to be aware of some of, when a patient does pass, ensuring that we're not getting, our food services people, our other allied staff and nursing staff walking into a room where a family might potentially be grieving. So we put a candle on the door. It's a very simple thing, but it did come from our staff quality improvement work. We've got our Healing Hours project, so we know how important it is for patients and families to be together, so we've removed all of our visiting hours, but we do want to ensure that that healing time is protected. So rather than having visiting hour signs on our units, we have our healing hours, so quiet hours are from 9 p.m. to 9 a.m. We'll just kind of pull through, just wanted to share some other pictures of our story and such. And then you were always asked about kind of our results and where we've come. So we have really had a lot of success around integrating holistic care planning, so having all of our different team members support care planning, including our physicians and geri-psychiatrists. One of our big wins was the decrease in violence on the unit, which is really important both from a patient safety and a staff safety perspective. So our code whites, which is what we used as our metric, decreased by 85%. And a lot of that is around the environmental changes. It's around making sure that we've got the right care plans in place and we're supporting the right behaviors. We have decreased our use of antipsychotic and physical restraints. I'm proud to say we got rid of a lot of brodas. So you saw them cluttering the hallway, we'll actually realize we didn't need them anymore. So hopefully those have been removed from the bowels of the hospital, but we don't use those quite as much anymore. We're still struggling a little bit with the one-to-one. There are some patients that do require that one-to-one attention, so that is often an issue in terms of budget and just getting actually those resources in play, but we have seen a slight decrease. We also got some very generous funding from the foundation around creating a program for one-to-one TLC support, so we're working through that. We had a steady decline in terms of falls, and we've had anecdotal feedback from patients and families about the care experience there. So we haven't quite collected that formally, but we have seen some really, really great results. So, anything else? I think that's everything for us. Thank you very much.
Is there one there? Back way. So I need to disclose my own bias. I love these guys. I'm just extremely proud of the work that we're doing at Vancouver Coastal Health. But I just want to say thank you all. We did run over. I apologize for that, but we heard 3 amazing presentations. I hope you're leaving here with inspiration and encouragement to take this forward. So thank you all, and thanks to everyone. If you have questions, would you guys be willing to stay? Okay, so they'll stay and you can come up. Please complete your evaluation, because that tells us about how we did and how we can do better. So please take a moment to do that. Thank you.